Thank you very much for waiting. We'll now start the comprehension of Asian HCC by HOC study and APASL HCC guideline, chaired by Dr. Masao Omata and Dr. Lei Wei, please.
All right. I would like to chair this session with Professor Wei, and sunny outside, but please stay here for a while. And first speaker of this session, and this is a very important session, I think, for the sake of the patients and for the sake of the APASL. And the first speaker is Dr. Mochizuki, and he will touch upon how he started this HOC studies, Hepatology Oncology Consortium. So could you start your lecture, please?
Thank you, Professor Omata. I'd like to say the great pleasure to honor to speak here today. I'm data manager for HOC study. I'm going to talk about the progress of HOC study and the overall picture and heterogeneity that can be seen from the data. First, a brief overview of the HOC study. This project will enroll approximately 10,000 cases from Asia-Pacific countries and regions, analyze real data on diabetes, obesity, and new drug therapies, answer many clinical questions, and develop a APASL guideline. The HOC study conducted in January 2023 with Professor Omata as a principal investigator. The study will include patients diagnosed with HCC since January 2013. The enrollment period is foreseen to December 2027. This study used REDCap for data accumulations. I'll skip the details of REDCap. It's a very secure and global standard data management system in academic medical research. 17 institutions listed here have IRB approved under enrolling patient. The HOC study is collecting data on about 100 items, but the input method is designed to be as easy as possible. The figure shows the number of registered institutions and the number of registered patients to date. By last week, 17 institutions has the IRB approval and are enrolling patients. About 3,500 cases have been registered in the first year since the start of HOC study. Thank you for registering on many cases less than a year after the first IRB approval on March 2023. One of the features of REDCap is the use of dashboard that allowed you to see the contents in real time. Here's a snapshot of the dashboard from last week. Anyone registered in HOC REDCap can check it. It is possible to get an overview of all data. We can download the data from REDCap in a variety of formats in suit our method of analysis. We can use it, learn about the real world, and solve many clinical questions. Next, I'll focus on what is the HOC data reveals. We'll start with the simple items. The mean tumor size in 2,800 registered cases was 5 centimeters and is also indicated as such on the dashboard. When this was expressed as a histogram, the mode was 1 to 2 centimeters. The figure above shows differences in the tumor size by country and regions. The figure below shows by institutions. We can see the HCC of the HOC study shows these degrees of difference. Next, we look at the etiology. The etiology of all registered patients is also seen in the dashboard. As is well known, the etiology varies widely from country to country. Green bar is HBV, and orange bar is HCV. In addition, we can see the inter-institutional differences in background etiology as well. I would like to show the chronological changes in the ratio of viral or non-viral HCCs in Japan. The purple bar indicates the viral hepatitis. Thus, HCCs in the Asia-Pacific region showed dynamic change, both regionally and over time. One of the most important aspects of the HOC is treatment. This figure shows the overall picture of what treatment was chosen, and multiple responses are allowed. RFA and TACE are the most used therapy as local regional therapy. Sorafenib and lenvatinib were the most commonly used drugs. Atezolizumab and bevacizumab are next most selected. New ICIs are also beginning to be used. It should be noted that there are reviews for all countries for entire period, including various degrees of liver damage. This slide shows what treatment is chosen for each BCLC stage. The vertical axis shows the percentage of patients within each stage selected for the treatment. RF is mainly selected for stage 0 and stage A patients, including by yellow or green bars. TACE is selected in stage A or B by green or blue bars. Chemotherapy is mainly administered up to stage C, indicated by purple bars. And fewer treatment options at stage D, indicated by red bars. The treatment is being conducted under the guidelines. However, there will be some differences depending on the region and the time of year. It shows that what combination of treatment was most common, regardless of timing of treatment. For example, patients who had TACE often had RFA during the course of treatment, and many more received sorafenib and lenvatinib. And the patient treated with atezolizumab often also received bevacizumab. The initial treatment date is enrolled in HOC study, so the order of treatment and type of combination therapy can also be analyzed. Furthermore, the data can be compared by country or faculty. This shows the new systemic therapies chosen in each country, real number. And this shows the ratio of systemic therapies selected in each country. The use of lenvatinib is biased towards Japan, China, Indonesia, and the proportion of sorafenib is relatively lower in Japan, China, Indonesia. And atezolizumab is used in Japan, China, and Turkey. In addition, the use of newer immune checkpoint inhibitors is particularly high in China. This graph shows the chronological change of chemotherapeutic drugs. Initially, sorafenib was the only choice, but then lenvatinib appeared, and also from 2020 to 2020, atezolizumab has been used, and recently, new ICIs, including pembrolizumab, have started to use. Of course, such chronological drug changes needed to be considered, including regional differences. This is a patient overall survival for initial diagnosis, which is now all registered patient. MSD is 5.3 years. That shows the patient prognosis by country and institutions. These outcomes of patient prognosis influenced by various background factors. We can find better options by considering various background factors, including treatment. Thank you very much.
Thank you very much. This study just began, but for the last maybe essentially for 8 or 10 months we collected, and then really thanks for the contributors. But this is maybe the real world data, and this is maybe more important than the champion data provided by the company. And any question for this model? Because Dr. Mochizuki has to leave a bit for the other session, right? So if there is any urgent questions, please. And then this may continue because there is another study going on in APASL, that's a hepatic failure group, and then Shibsarin is chairing, and then it's lasting almost 12 years, and then today spending almost 10 hours about hepatic failure. So maybe I think the hepatocellular carcinoma are the same, especially in this area of world. We got to continue this study. So thank you very much.
Thank you very much.
Thank you very much. So then we invited Dr. Loho, Imelda Maria Loho from the Indonesia, and she will talk on the hepatocellular carcinoma in Indonesia. Please.
Good afternoon, Professor, Doctor. Thank you very much for the opportunity, and thank you, Professor Omata, for inviting me to this very important session. For the committee, please change. The slide is not mine. Can you switch to my slide? Indonesia.
This is from Mongolia. Indonesia.
In the schedule should be 3:50, I think. Okay, yeah. Okay, so before we have the slides, I would like to explain a little bit about this project. So I'm on behalf of my senior, Dr. Lianda Siregar from Darmais Hospital, and also Professor Inogani, that is one of the steering committee in APASL, who is the one who invited at the first time by Professor Omata to join this HOC registry. And Professor Inogani asked me and Dr. Lianda from Darmais Hospital to also join this registry. And fortunately, we have the IRB approval approved in July 2023. So we are starting to input data from since November 2023. Okay, so this is also my senior, Dr. Irsan, Dr. Rinaldo Usmana, and also Professor Inogani. So as we know, liver cancer is the top 3 causes of cancer-related death, and the number will rise highly in the future. And what we have in Indonesia are a very high number of cases with high mortality. We have 1-year survival rate very low, 48.2% from our last data. We have no surveillance program for high-risk patients that are routinely done in the primary care. And we have also lack of treatment facilities and reimbursement, and no HCC registry at first. So on September 2022, the Indonesian Association for the Study of the Liver, at that time the president was Dr. Irsan Hassan. He initiated the Indonesian National Liver Cancer Registry. So we started to collect data from all over the Indonesia. And in January 2024, we have 20 hospitals across 14 provinces that also collect data through the RedCap software, and we have now 2,035 patients. This is the chronology of joining the HOC, and because the approval only came from the Darmais National Cancer Hospital, so we can only input the data from this hospital. So what I would like to present now are data from the Darmais National Cancer Hospital. We have actually 222 patients, and with as mentioned by Dr. Mochizuki, the most common etiology is hepatitis B, and we have high median AFP level, 908 nanogram per milliliter, and most of our patients have AFP above 200 nanogram per milliliter. 20% of patients were obese, and we have large tumor diameter with median of 10.2 centimeter. Most of them also have multiple nodules, but the cirrhotic liver was found only on 42% of patients. The portal vein thrombus was found in 26%, and metastasis before treatment 16.2%. Patients classified as LB grade 1 and child PUA are the most frequently encountered. So most of them have preserved liver function. Type 2 diabetes was found in 14% of patients, and gastroesophageal varices in 22% of patients. BCLC stage B is the most frequently encountered in 35.1%. And we have the first line treatment, actually is very bad because the most common one was the best supportive care because of the lack of facilities and also the reimbursement. But we have also some patients have TACE and lenvatinib as the first line treatment modalities. Our 1-year survival rate is 60.4%. And our obstacles in collecting the data is the incompleteness of retrospective data. And it's a bit difficult for us to classify the patients according to the etiology of NAFLD because most of our patients do not have a previous health record, so we cannot retrieve whether they have previously been diagnosed with fatty liver or not. And some of them came to the doctor at the first time when they were diagnosed as HCC. And the other obstacle are we are still unable to retrieve the whole data from the HOC, like the one that I show you to do the survival curve analysis. We still have to do it from our registry. So my conclusion is large tumor burden at diagnosis and lack of adequate treatment contribute to the poor prognosis of the HCC patients in Indonesia. So more rigorous efforts such as National HCC Surveillance Program are needed to increase the number of early stage HCC at diagnosis and to improve the patient survival. Thank you so much.
Thank you very much. Sorry, it's my simple mistakes. You are the third, and then and the second is Mongolia. So sorry about.
It's okay, Professor.
But anyhow, you know, we are asking 110 parameters, so that's a lot for you. Thank you very much. And then, and I also saw that this might have stimulated for your country people to get the data together, don't you? In other words, you may able to make a group in Indonesia, including you and your other hospital. Is that true?
Yes, that's true. Yeah.
Yeah.
So, the registry is from 14 provinces, but what I show is the data from the Darmais Hospital.
Right.
Yeah.
Yeah. All right. So we can discuss later on. Thank you very much. Yes.
Thank you, Professor.
ありがとうございます。So the other second one is from the Mongolia, and then Jazak, could you present your data from Mongolia? Actually, we are happy enough to have including the East Japan, North Mongolia, and then West Turkey, then South Indonesia, then Central China. So those four different, completely different areas covered. So Northern Mongolia, please.
Good afternoon, dear distinguished guests, professors, hepatologists. Thank you very much for this opportunity. And Mongolia became a member of HOC very recently. We started data collection by the end of the last year. So far we have 270 cases of HCC registered. So before going to HOC, I would like to talk about the current situation of HCC in Mongolia. So HCC, this is a very famous graph published in Lancet, I think almost 10 years ago. It showed that Mongolia has the highest rate in the world in terms of HCC incidence and mortality, and this one shows that we are 6 or 7 times higher than the world average. So of course there are causes of HCC that are mostly of viral origin, but these days the other causes, non-viral causes, are increasing as other countries. So this is a 10-year cumulative incidence of HCC in Mongolia. We have roughly about 1,700, between 1,700 to 2,000 something incidences per year each year, and the incidence is not gradually going down, but is somehow stable, or sometimes it increases. And the lower blue bar shows the relative share among other cancers of Mongolia, which is about 38 to 43% of all cancers of Mongolia. So this is a 10-year HCC mortality number, and this is in the last 10 years we had lost 21,000, more than 21,000 citizens due to HCC in our country. So if you say calculate the cumulative survival, is about 19% has survived it so far. So the sex distribution of HCC patients, as any other countries, mostly male are dominant. And the diagnosis, the stage at the diagnosis is mostly about 80% of all cancers are diagnosed at the stage 3 or 4, and the rest is stage 1 and 2. So HCC location within the country, this is the province by province incidence rate, and somehow some provinces are very high in HCC, maybe due to intake of huge amounts of meat as a diet, could be, because this very high province, this place is famous for its very delicious meat. So maybe it could be one of the causes, but we haven't done much research, but it could be. So HCC diagnosis-wise, we have almost every modalities of HCC diagnosis. We have ultrasound, CT, MRI, pathology, angiography, and tumor markers, AFP, PIVKA2, and L3. So management-wise, also we have almost all of it besides the radiation therapy. We have liver transplantation, surgery, RFA, ablation, and TACE, sorafenib, and lenvatinib, atezolizumab, and bevacizumab. But the last two were registered like a few months ago, so there's not much data on the last two regimen. The sex and age distribution among participants in HOC study. So in the young age, mostly males predominant, but somehow between the age of 60 to 65, female HCCs are more than males. So this is the number of primary and recurrent HCCs within the registration. So about 100 patients were primary had primary HCCs, and the 169 patients were recurrent HCCs or post-treatment HCCs. So this is a number of patients who had treatment or not. So there was only 3 patients who didn't have any treatment, maybe because of its very too late diagnosis, and there's only maybe palliative treatment available, so we count them as untreated. So cause-wise, it's almost like any other country, but HCV related HCC has decreased from almost 50% down to 26%. And now half of our HCCs are HPV-related HCCs, and others are non-viral causes. Maybe there is NAFLD, NASH, and 7% comprises of alcoholic liver disease-related HCC. So this is the cause and also the sex distribution. So if you see here, of course, alcohol-related HCC is much higher in men in Mongolia and much lower in female HCC patients. So this is the death during the AHOC surveillance in Mongolia. We have 26 patients died in the last few months. And there are some patients who were lost during the follow-up. We don't know if they are still alive or not, but we lost contact. And this is the patients. 84% are still alive. So we checked the causes of death of those 26 patients, and it turns out to be 2 died from accident. Road accident, 6 died from the stroke, and 18 patients died due to HCC itself. So this is the years since HCC diagnosis until death among those patients who had died, and 15 patients died within 1 to 2 years after diagnosis. 7 patients died after 2 to 3 years after diagnosis, and 2 died 3 to 4 years after diagnosis. And this one is 2 patients died within 1 year. So these are the treatments received for those deceased patients. So they had ablation and TACE, and some sorafenib, and also ablation plus surgery. So these are our patients who are still alive. They are being followed up, and we checked what kind of treatment they are having. And many of them have sorafenib, and many has surgery and ablations. And this is the distribution of management they are having right now. So this is the number of open surgeries who had only surgery. So there's 176 patients had only 1 time open surgery, and 12 patients had 2 times surgeries, and 3 patients have 3 times of hepatectomy. So this is the ablation. First, 1 time ablation is more than 240, and 2 times 84, and 3 times 32 patients. And this is the number of TACE we received, and this is the sorafenib treatment duration, because we started the AHOC pretty recently, and sorafenib was accepted by National Health Insurance pretty recently. Most of our patients are having sorafenib in the last few months. So this is the lenvatinib, but lenvatinib is still not registered, so most of our patients are getting it from other countries by themselves. So this is the information about background cirrhosis. 168 patients, or 62%, is positive with liver cirrhosis, and about 40% have HCCs without cirrhosis. So this is the HCC with cirrhosis, age, and sex distribution, nothing significant, but mostly male. So this is the information we have so far. Thank you.
Thank you very much, Jadak. You know, how many cases are you supposed to be able to collect? And
We
then
will
by the number, I judge your influence.
Yeah, by the number, it's a huge number.
But how much influence you have? How many you can collect?
Well, I think we can collect at least 1,000 within 1 year. Yeah.
You know, because to the people, my question seems absurd, but because he's my student, so he's 日本語で喋れるから大丈夫なんですけど。Yeah, got to get at least 1,000.
That is, I think, outpatient, and also reaching out to surgeons and those who are doing invasive treatments. They might.
Because he was one time a politician, so he was an influential person, in fact. And
Yeah, I think we can come up with a good number very soon.
yes, so then that case you became the politician again. But anyhow, we asked the 110 parameters, so that might be too much for some countries. But I think, in other words, that's our common practice. You know, we have 110 parameters, including the 3 types of the tumor markers or different types of the modalities of treatment. But as far as I judge, now the Mongolia is really catching up, and then only not available thing is one, the drug, systemic therapy, but they obviously will catch up. So then we can be on the same standard and then can discuss what's going to happen. I think this is a very important template. And also he learned how to do the RFA in Japan. So he is also the student of the Shina sensei. Yes. So the quality may be guaranteed. So we're going to discuss later. Thank you very much.
Okay, thank you.
Yes. What's about? Yeah. Any urgent burning questions? What?
The transplantation is the main treatment of the APASL carcinoma.
Yeah. Well, yes. Some country, yes. Yeah. So what?
How about in Mongolia? Do we have the transplantation program?
Yes, we have 2 transplantation programs running. One is at the Central First General Hospital, and the other one is National Cancer Center.
Right.
And we do treat some patients with transplantation for those who have liver failures with some HCC.
So that could be beyond Japan, because we don't have donors. They do have. Yes. See, so that's so many questions, differences we have. That's why we have a template, platforms. Yes. Thank you very much.
Thank you.
Mm-hmm. Yes. And then I finally inviting the third one is from Turkey, from the west of the Asia, and then Professor Murat is Mushim Harpurtulungur. So could you start your lecture from the Turkey, please?
Dear Chairman, dear colleagues, firstly, I would like to thank Professor Omata and Professor Dökmeci. He is our mentor. I present instead of my friend. My name is Murat Harputluoğlu. My presentation is Comprehension of Asian HCC in Western Asia, Turkey. Previously, we used Turkey, but now official name is Turkey, our country name. You can see cancer statistic in Turkey 2020. Our population 84 million, and new cancer case 230,000, and cancer-related death 126,000. Hepatocellular cancer rank 14 in Turkey, new cancer case. And in the death, hepatocellular cancer rank is 7. Abdülkadir Dökmezi is our mentor. He initiated all center in Turkey and motivated. Thank you very much again. Murat Kekili, friend, our friend, he took the approval of ethic committee institution. This is the National Resource Centers. My city is Malatya, is the highest volume transplant center in the Turkey, and the other cities. Research process, as you know, the study protocol was translated into Turkish and sent to the participating centers in SPSS and Excel format. The data received from the centers participating in the study were subjected to a pre-evaluation. After deficiencies and inaccuracies were identified, they were sent back to the center for correction. Most reliable data possible were obtained, and these data were entered into the red cape by a single person, the Professor Murat Kekili friend, to ensure standardization. Now, as we know, Turkey is the third rank, the most patients, 274. And you can see the IRB approved institutions. In our results, majority of patients was male, 71%. And you can see diagnosis, mostly 60%. And performance status, majority of patients, performance HOC status 0. And child push score, child A, majority of patients. Etiology, most common cause, hepatitis B, 55%. And later, NAFLD is very common in Turkey. This year, our society published a paper in changing transplantation. NAFLD now is the most common problem in the Turkey. Previously, most common problem was hepatitis B. BCLC staging, most of patients stage B, later stage A, later stage C. Treatment options, most common TACE and transarterial embolization. And 13 patients transplantation. And 4% open surgery. And 26% no treatment. You can see treatment response is the big picture. You can see the complete response rates, open surgery 1, TACE 3 patients. Follow-up, the 44% alive, 54% death, and small number unknown. Cause of death, majority of patients, liver-related causes. And 14% unknown, and 5% non-liver related. Conclusions: 14 centers representing the majority of the Turkish population are participating in this study. There is invalid data in the first incoming data as it consists of retrospective data. For now, the data of 263 patients who were pre-evaluated and entered into the Red Cape were discussed. Thank you very much.
There are two Murat.
Yes.
And then
Yes.
sorry, thank you for coming. And I was amazed to the follow-up rate is so high. So maybe because of the liver transplantation programs and the patient follow, you are come back to your hospital, right?
Yes. Now 500 transplanted HCC patients we have. I hope gradually I will enter the system.
And then you can make a kind of the umbrella type of the groups in Turkey, especially somehow related to the Professor Dogumeci, students, friends, younger colleagues, and they make a bigger. Could you? Like 3,000 cases from Turkey. I need your comment. Yeah, and then this one in particular, you mentioned a little bit about the retrospective character of this study, but this is a combined retro and then prospective. So from now on, we can go into the prospective study, especially if you combine transplantation and systemic therapies. Maybe that can be very interesting data for the future. So thank you very much. 谢谢，ありがとう。
Thank you very much.
And next, we will invite Professor Yang to introduce the China data. It's Central Asia. And Professor Yang is my colleague, and she's the director of Department of the Hepatobiliary Cancer under the umbrella of the Hepatopancreatobiliary Center. And so, Dr. Yang, please.
Thank you. I'm Ming Yang from Beijing Tsinghua Chang'an Hospital, China. It's my honor to report the comprehension of HCC in Central Asia, China. Thanks for Dr. Amanta to invite us to join the HOC study. Till now, we have input 200 cases in our center. But in other centers of China, there are only 20 patients. So in this slide, I don't focus on the data detail of the HOC in China, but on the situations of HCC in China. The first part is the prevalence of liver cancer in China. As we know, China has the biggest burden of liver cancer in the world. And the HBV is the most common cause of HCC. About 70% of HCC patients in China are in the intermediate and advanced stages. The 5-year survival rate was about 40% throughout 2010 and 2014 in China. Because of the high incidence rate, high mortality rate, relative late stages, and poor prognosis, the treatment of liver cancer in China has always been the key and difficult point to be solved urgently. But we should notice that the incidence and mortality rates of liver cancer in China show a significant downward trend from 1990 to 2019. The second part is about HCC management in China. China has our own liver cancer staging system. Compared with BCLC staging system, we can see a big difference of treatment selection between China and the West. The indication for liver resection in Chinese liver cancer guideline is relatively broader, but we don't pursue surgery blindly. For early stage HCC, we recommend precision surgery. For intermediate and advanced stages HCC, we recommend conversion therapy with sequential curative surgery. Academician Jia Hongdong advocated the concept of precision surgery. The strategy of precision surgery is to seek a balance of maximizing the removal of the target lesion while maximizing the functional liver remnant and minimizing surgical invasiveness. In recent years, scholars in China also issued a number of expert consensus on the conversion therapy of liver cancer. The above consensus states that local and or systemic therapy creates potential curative resection for initial unresectable HCC and translating to survival benefit. Scholars in China also conducted a number of RCTs of HOC, which cover multiple stages of HCC and got positive results. As we know, 193 is a precise nuclear strike to liver tumors. In November 2022, Tsinghua Chang'eng ETM-90 Precision Liver Tumor Interventional Radiotherapy Center was established. This is the first patient in our center treated with Y90 in Chinese mainland. It's a young male with CLC stage 3A, BCLC stage C HCC, and CR was achieved at 3 months after Y90 treatment. And then the patient was down stage 2 surgery. The pathology showed that only 4% tumor cells were alive. At present, there are 700 cases of Y90 treated patients in Chinese mainland, and our hospital has completed 160 cases. MDT is strongly recommended for HCC management in BTCH and China. Our center, the Hepatobiliary and Pancreatic Center of Beijing Tsinghua Chang'eng Hospital, integrated hepatobiliary and pancreatic surgery, liver transplant department, hepatobiliary medicine, oncology, intervention, and liver ICU together to provide one-step service for HCC patients. The third part is prevention and early screening for HCC in China. The Chinese government has taken a series of measures to prevent HCC, such as hepatitis B vaccination strategy for children, appropriate expansion of antiviral indications, and the prevalence of HBs antigen among children under 5 years old in China is the lowest in the world. We also pay attention to early screening of HCC. China has gradually launched 3 major national public health service projects and conducted guidelines and expert consensus on the early screening of HCC. But we have a long way to conquer HCC in China. Thank you.
Thank you, Professor Yang. Any comments and questions from Fru?
Well, at the end, there are many ways to treat the patient, but I think the only standard is length of life. So but that have to be adjusted by the baseline data. So maybe the international comparison is possible by adjusting the baselines and then outcome. So in between there is a modality like you just show. So that's very important for the international comparison, and then share each other information so possible. Thank you very much.
Thank you.
Okay, thank you. You are the invite next speaker, and Rikosaka Takeshi from Japan. Please welcome Dr. Takeshi.
Good afternoon, everyone. It's my great pleasure to be here and speak about the HOC study in Japan. And my presentation title is shown here, Comprehension of HCC in Eastern Asia, especially in Japan. So I have nothing to disclose regarding this presentation. This slide shows the rapid increase we have encountered in the early 70s of HCC increase. This slide shows that we have observed the rapid increase of HCC before the discovery of chronic hepatitis C. When we checked, we were able to check the hepatitis C status. It appeared that most of this increase was caused by chronic hepatitis C. I added this slide to my presentation for the memory of late Professor Okuda, and also I want to share the status of HCC 40 years ago. At that moment, this is from the quite famous paper, and you can see that the median survival after the diagnosis of HCC is only 4 months. Even after resection, the median survival is as low as 20 months. So we need to establish a screening system to find the tumor in size, especially in patients with chronic hepatitis C. And also, we poured our effort to, eradicate hepatitis C from Japan. So partially we have achieved. So as an introduction, also hepatocellular carcinoma has aspects of both infection-related and lifestyle-related malignancy. The one is, of course, the chronic hepatitis B and chronic hepatitis C contribute to hepatocarcinogenesis. Also, we are facing the new era of obesity-related liver diseases and the cause of liver cancer. In parallel with the decline of the HCC-associated HCC, HCV-associated HCC, we are facing a non-viral HCC. This slide, again and again, we repeatedly show this slide to indicate the non-viral HCC, as indicated in red, is increasing so rapidly in parallel with the declining proportion of HCV-related HCC. When we calculate, we multiply the incidence of HCC based on our nationwide registry and the proportion of non-viral HCC based on our nationwide survey. If you look at the number, in 1992, there is only 2,200 cases of non-viral HCC in Japan. However, in 2015, we diagnosed 1,300 of cases, and more than 5 times increase in the last 2 decades. The major cause of this increase in Japan might be shown here. As you look at the left side, this slide shows the proportion of the proportion of the population, males, who has BMI more than 25 kilograms per square meter. In any kind of generation and any kind of age groups, we are observing the increasing number of obesity patients defined by the BMI more than 25 kilograms per square meter. On the other hand, the Japanese females are not have such kind of trend. And when you look at however, when you look at the proportion of those with obesity, defined in Asian criteria, not Western criteria, gradually in females, also in females, the proportion of obesity gradually increase according to the age. So we are also seeing the more and more population with fatty liver disease, and this indicate that at this moment 30 to 35 Japanese males are affected with fatty liver disease. Also, 15 to 20% of females have fatty liver disease. So that may be a cause of rapid increase of non-viral HCC in Japan. I would like to go back to the situation 20 or 30 years ago. When I was a resident, we were treating patients with interferon monotherapy in 1995. Then peginterferon appeared, and then we got the peginterferon ribavirin therapy. But that is not indicated for most patients with old age or liver platelet count less than 100 per ml. However, as you know, a DA appeared in 2014. Then we can eradicate the hepatitis C with a high SVR rate. That it can be applied to those with old age, liver cirrhosis, or renal failure. Any kind of patients can achieve SVR nowadays. So this slide shows the number of treated cases in a hospital from 2014. As you can see, the Harmony is, created a large mountain, and we have introduced more than 100 cases in 2016 per month, and almost all of them achieved SVR. That might contribute to the declining incidence of HCV-related HCC in Japan. And when we look at the number of patients who are with chronic hepatitis C or viremia, when you look at the right side, the proportion of SVR now increased to more than 80%. Actually, as of 2023, almost all patients achieved SVR regardless of the cancer development. So as a background, as an introduction, I explained the background situation of Japan, especially focusing on the etiological background. Then I would like to talk about the current status. As Professor Dr. Mochizuki mentioned, APASL Hepatology Oncology Consortium called AHOC was established, organized by Professor Omata to capture the status and the management of hepatitis and the liver cancer status in the Asian Pacific region. So we are the first initial launching society or hospitals. It's a retrospective, as mentioned by Professor Omata, prospective, or also prospective study to enrolling 9 patients since 2013, and it's still ongoing. And when you look at the median age of Japanese patients with HCC, you might be very impressed to see this is current status, including the 10 years ago cases with 10 years ago. But Japanese patients are oldest old, and we are seeing that maybe at least 1/4 of patients are over 80, and we are these days we are thinking about the dementia for those population, and maybe more radical therapy is not indicated for oldest old population, and they are getting older and older according to the timeline. And if you calculate the mean tumor size, it was as large as 4.2, but as you can see here, the histogram was very skewed, and the most frequent category is 1 to 2 centimeter in diameter, and the median size is around 2 to 2.5 centimeter in diameter, thanks to the surveillance system still working. And however, when you look at the mean tumor size, separated by the institutions, there are wide difference between the institutions. When we look at the left one, Tokyo University, because that Professor Obi was receiving the more advanced cases referred to his hospital, the tumor size is as large as 7.3 centimeter. On the other hand, at our institution, on the right side, we are receiving the referral cases who are indicated for radiofrequency ablation. The tumor size is 3.1 centimeter. And the etiology is changing as I shown in the previous slide. When you look at the proportion of HCV or HBV patient, as mentioned by Dr. Mochizuki, the proportion is declining, and also diverse among the institutions. Yeah, this one indicates the rapidly declining proportion of the patient with chronic hepatitis. So we need to establish a new system to find the tumor small in size in non-viral etiology, because we don't still have effective surgery strategy to find the tumor small in size in so-called MAFLD patients or alcohol-associated liver disease. When we look at this, shift from the sorafenib to other agents in advanced liver disease, advanced liver cancer, sorafenib was be able to use in 2009, almost 14 years ago. Then we have to wait for almost 10 years to see logorafenib. Then we got lenvatinib. Nowadays, the atezolizumab, bevacizumab was the first-line treatment for advanced disease. Well, you might notice that the number seems to decline, but we are now inputting the data from the oldest data. So that kind of data in the recent days is not so complete. When we look at the survival curves, survival or status of our patients in Japan, you may remember that the median survival was only 4 months 40 years ago, but today we can get more than 5 years survival, and we can expect a 10 years survival today. However, if you stratify the survival according to the institutions, based on the, reflecting the staging of a difference in staging among the institutions, the survival curve might be slightly different among the institutions. So in summary, rapid transition from viral to non-viral etiology, HCC in Japan was observed, as I mentioned. Tumor stage vary depending on the situation on each participating hospital, reflecting the situation of their location. A first-line systemic therapy was shifted from sorafenib, lenvatinib to atezolizumab, bevacizumab now. Thank you for your attention.
Thank you, Professor Tadashi. Any comments and questions?
There are so many clinical questions can be answered by this cohort. For example, just a simple Kaplan-Meier curves may tell you so many things. How do you think about it? Because, for example, we are using a BCLC, but in the oncology area, BCLC is okay, but when I actually check my data in my hospital, I think rather UICC or TNM classification is much better showing the stratifications. So maybe, and then again, oncologist joining, maybe it's time to not just specific for the hepatologist, but rather going to the original TNM. How do you think? And then that can be checked. By showing the stages, there are 5 classes, 1, 2, 3, 4, and everybody. And in this meeting, everybody concentrating intermediate stage, but other oncologists doesn't understand what's talking about.
Yeah, really. Other oncologists are using the TNM stage, 8th version. And
so by testing that, it's not that discussions. Okay. Make the Kaplan-Meier according BCLC, according to the stage 1, 2, 3, 4, and then what's gonna classify and then stratify. We can do that. So that's just one of the clinical questions I just had in my mind. So you have so many questions, right?
I have so many questions, but I do like to emphasize that liver function is not included TNM staging. And you remember that the first Okuda is the first one to show the balance between the tumor burden and the liver function reserve. However, these days we are seeing the more and more patient with good liver function. In that population, TNM staging may work because, those are, under antiviral treatment of hepatitis B, and those are who achieved SVR, and they have a good liver function. And some population of non-viral HCC has non-cirrhotic liver. For that population,
I'm not saying just a matter of discussion. I just checked the 16 years data of our 1,100 cases. Then I just simply compared whether it's IBCLC or stage 1. And then either way, I mean, staging 1 to 3 is much easier, and then can tell the differences clearly. I can show the data later on. But I'm saying we can test that by this cohort. Then we can discuss about it. So those are the clinical questions that we can answer. That's the point. All right, thank you very much. Then this is the, I think, 5 different countries, the area of Asia, right? East, and then Turkey, then Mongolia, and then Indonesia. Okay. Then we have the speaker from the Dr. Ogasawara. Yeah. Yes.
Please chair
then
the panel
George
discussion.
Lau, Professor George Lau. So which one comes first?
And I want is the Satahisa.
Oh, Ogasawara sensei. Okay. So wait, George, wait. Yes. All right. So then we gonna discuss about the features, and maybe we saw the differences, not completely enough, but we saw the differences of the areas and the areas. So the Asia is so widespread, and then hepatocellular carcinoma also, the clinical picture is so different. But based upon those, we may have to make guidelines, or at least clinical guidelines needed for the sake of patients. So then we're gonna get started. Oji Sensei, welcome back. Yes. Could you stay there? Oh, all right. Yes. So Professor Ogasawara, please.
Hi, good afternoon, everyone. And my name is Salahisa Ogasawara from Chiba University. I'm great honor to talk here today. So I would like to talk about the target of APASL guideline. And here's my disclosure. As you know, that liver cancer is a major, health care problem in Japan, ASEAN. And also that in 2020, ASEAN accounted more than 70% of global incidence of HCC and global deaths of HCC. So, and if you in the future trend of new HCC cases are more increasing, so it's a big health problem in Asia. And also, let's moving back to 2017, Professor Omata and our colleagues created about APASL guideline, and number of citations is more than 1,800. Maybe it's one of the success guidelines in the Asian Pacific region. And there are 2 key points that when updating the guideline, it's based on evidence, it's of course, and also the university used in the Asian Pacific region. So it's been the APASL HCC guideline is not only the medical environment maintained country in the high-volume center, but also all of the Asian Pacific region's people. So the diversity of medical environment in the Asian Pacific region has several key points. There are 4 key points. The skill of medical staff, difference in medical equipment. Also, the system of medical insurance is so important, like a reimbursement or approval, such as in the Mongolia cannot use a reimbursement. Some of these kind of problems has big issues, and also economical disparity. So one of the the example for the economics in Asia, there are significant disparity of GDP per citizen among the country and the regions. Moreover, there are also substantial difference in the proportion of GDP spent on healthcare. This is the data from the World Data Bank. In all over the world, we spend about 10% of the GDP for the healthcare. But you can see in the United States, they use 18%, okay? But the EU, it's 10%, East Asia and Pacific, 6.9%, and also South Asia, it's only 3%. So there are big difference of the GDP, and also there's a big difference of health expenditure percent of GDPs. So diversity and rigidity of the guidelines. Also, guideline for each country or within the same regulatory, also such kind of EMA in Europe can be created taking account of the medical environment, equal medical environment and health healthcare insurance system of the country or the region. And it is possible to create a guideline which is certain degree for rigidity, like a Chinese guideline or BCLC, or Japanese guideline and Korean guideline, okay? The challenge of the APASL guideline, which I intend to be used by a country and region with a various medical environment, it's to what extent diversity and should be incorporated. So this is looking back to the APASL guideline of 2017. And one of the key points of this part of resectability, because about surgeon is one of the key players for the treating HCCs in the Asian Pacific region, but there are so many big differences with those skills or medical environment or each institution or each country or region or something. So at that time, we did not define about detailed resectability, but they should talk about each other. Look at this data. This is a little bit older data, but you can see that the majority of the staging receive a resection, okay? This is the pink bar is resection. So some patients receive resection stage B, but some patients receive stage C, BCLC staging C. So, and there are currently a lack of definitive evidence when it coming defining resectability. So rather than setting a rigid definition, it is considered more desirable to recommend that each institution determine the treatment policy after multidisciplinary discussion. This is a good point for the each institution or each surgeon or each hepatologist. Also, let's think about what happened about these 6 or 7 years about after 2017. First one is a reported RCC comparing peripheral resection RFA. This is Professor Shina or Mata or the Professor Kokudo in Japanese colleague tried to do such kind of RCT for small HCC. Also, several RCT or combination tests and systemic surgery have been published. Also, significant advance in systemic for HCC had happened. So look at this data for the self-trial from Japan. There are no big difference, decrease-free survival between surgical resection and RFA. So a resection RFA have a comparable outcome in small HCC, such kind less than 33 centimeters regions. Also, the taste and the combination of systemic therapy is one of the topic of the current situation. So let's look at let's moving back to the combination therapy with TACE and first generation VEGF TKIs. They are such called Sprivalimab, Sorafenib. At that time, the combination of the TACE and the VEGF TKIs stand the TTP or PFS or TTUP compares to TACE. However, that the impact of OS could not be proven. This is all the evidence. And also the other evidence come from China called the launch trial. This is lenvatinib plus TACE versus lenvatinib alone. This TACE has different strategy, but this TACE support about tumor intrahepatic control, tumor control plus lenvatinib. So look at this Kaplan. This data published in Journal of Clinical Oncology, prolonged overall survival compare TACE plus lenvatinib versus TACE. So some of the countries have already using about combination of the IVR plus systemic therapy in the current situation. Also, you can see that the MR1 trial, this is one of the TACE plus immunotherapy versus TACE trial. You can see the PFS improved, but there are no overall survival data yet. So, in this context, in actual clinical practice in the agent, treatment combined TACE and systemic therapy using agent that can be administered in each country region have already begun to be an active improvement in the Asian Pacific region. So, if we did those data is putting onto APASL HCC 2017 guideline to 2020, you can see that this 3 point is key point. We can perform a local operation for the recommended treatment like a small HCC. Also, generally, we have not data for prolonging overall survival, but we are using about TACE plus systemic therapy in a wide range of the patients who had intrahepatic nodules. So we just putting about this point in the algorithm, but the other basic contents is not changing. So that this is one of the idea. Then you can see that a lot of data is coming from the global phase 3 study or the local Chinese study. So now we can use a lot of agent in all over the world for the advanced HCC, but I think none of the all not of the one country can use every agent. So it's maybe sometimes difficult to, and making about the right and selecting flow for the advanced HCC, for the systemic therapy for advanced HCC. So, and also the other, agent will come soon, like Nivo plus EP, meets a primary endpoint. This is one of the data from the Bristol Myers the news release. So, and such as chaos situation for the advanced HCC has moving on to the next few years or 10 years. And also their gene potential Rembatinib HCC have proven for after the approval. Of course, improvement through the treatment experience, maybe how we can use about this drug. So maybe we can emphasize the true potential of these TKIs. That's why the Asian people like to use this agent. So nowadays, in the phase 3 trial, overall survival is only 13.6 months, but now if we use this agent, nearly 20% of the overall survival. So this is maybe cheaper than ICI, so sometimes we have to select this agent for the economical reasons. So various agents are available, and the indication for the systemic therapy differ from the country to country. Given the current situation in Asia, a flexible systemic therapy was maybe needed. So this is one of the conclusions for my presentation. The APASL guidelines should advocate a flexibility evidence-based approach to the diverse healthcare setting and the patient population of the Asian Pacific region, emphasize interdisciplinary collaboration and country adaptation to the emerging evidence. So thank you for kind attention for my talk.
Yeah, thank you very much. I think the message is clear enough because the basic structure of the algorithm of the APASL should be preserved because we have to be very flexible about. And then there are so many different rules, so maybe we can change some part of it, but not necessarily whole structures, right? That's your messages.
I think so, yeah.
Yeah, thank you very much.
Thank you very much.
All right. The next speaker is Dr. George Lau, and he will talk about mainly on, I think, systemic therapy. Yes.
Thank you, Professor Mata. And I really want to congratulate Professor Shina of getting this wonderful annual meeting conducted in Kyoto, a beautiful city, and our Japanese colleagues. In fact, I echoed a lot with all my colleagues in the room about the guidelines writing and the process of clinical practice guideline on a systemic therapy for hepatocellular carcinomas was initiated more than a year ago by me, myself, Chef Sareen, and also the Professor Mata. This is my disclosure. In fact, having heard about the ad hoc database, RADCAP system, it is really amazing to see different patterns of HCC. But our aim is really to understand what are the factors. It could be multiples, on affecting the overall survival so that we can manage and adopt to improve the patients under our care. Now, for the remaining few minutes, I would like to touch upon the main themes that has been generated on this APASL clinical practice guideline, which is a very short one. It's only part of the big pieces of the guidelines, just touching on the systemic therapies in HCCs in view of the rapid development of the TKI and also the immune checkpoint inhibitors and also the dual immune checkpoint inhibitors in the management of hepatocellular carcinoma. The process involves 3 chairs and also the panel members comprising different disciplines, not just hepatologists, but oncologists, surgeons, liver transplant surgeons, radiologists, and also the palliative medicines, pathologists in the different countries, comprising the members representing the 23 territories or the special administrative regions. Now, the process is pretty complicated. It takes a long time. It was initiated by the steering committee of APASL and the formation of expert panels chaired by myself, Professor Marta and S.K. Serene. We have circulations around, questions defined and responses from expert panels obtained by questionnaires. It is a tough process because different peoples really manage to hepatocellular carcinoma pretty differently, and it takes a long time to get some consensus. The draft recommendations was presented 2 days ago in this meeting and again here. And because we all want to hear more comments from different peoples in different disciplines in different territories, and modifications hopefully will be performed after this APASL annual meeting. And then we would, the publication, the draft, will be circulated and submitted to Hepatology International for considerations of publications. And the grading of the systems is based on the grade system. And the recommendations is mainly on a few areas. The first questions we ask is who should manage patients with HCC with systemic therapy? And it's almost a must that we adopt multidisciplinary teams with experienced specialties in various areas. And so we have alluded to that previously. And the second question is which patients of HCC should be treated with systemic therapy? Well, there are 3 areas: patients with unresectable HCC not eligible for local regional therapies with good performance status and relatively good liver functions. And the second category is patients with HCC who are at high risk of recurrence after tumor resections or ablations based on the size, numbers of tumors, and presence of cancer cells within the blood or lymphatic vessels and tumor grade. And thirdly, because based on the recent Emirates 1's phase 3 studies, patients with embolization eligible unresectable HCC. Now, these recommendations are all based on phase 3 studies, so we understand there are lots of phase 1 and 2, but our emphasis is really on overall survivals, and phase 3 studies usually have this data. The staging system, as alluded by my previous speakers, is based on the APASL guidelines, which was published by the Professor Martas and the teams in 2017 of the applications of systemic therapy. Now, one of the key questions is resectability. It's a very tough question, and we received different versions and answers based on these questions, and there are different staging systems. But in essence, it's really the experience of the surgeons themselves and the centers which decide resectability. And in order to accommodate the terms resectability, I think at this moment, patients without extrahepatic spread, without diffuse infiltrative extensive bilobular liver involvement have well-defined nodules with preserved portal flow. However, in special centers with a lot of experienced surgeons, they might extend beyond. And in fact, one of the few replies it mentions that even bilobular involvements could be dealt with by the local resections plus ablations, and they have data showing that it translates into long-term overall survival. So I think that this is really a guidance, and it is not a must. It all depends on the center's expertise and the surgeons and the facilities and so on. So the fourth questions we answer is which systemic therapy should be used as first line, and when will we switch to the second line or third line, and what will be the treatment of choice. This is summarized here. Try to make things simple so that it could be more practical to be followed. This is the treatment algorithms. Patients with unresectable HCC not eligible for local regional therapy with good performance status and good liver functions. And in those, it is segregated into 2 pieces, 2 paths. One is those who have resource limitations, without resource limitations, and has no contraindications to immunotherapy. Then the first line should be the anti-PD-1 and the anti-VEGF, that is based on the IMbrave 150 studies, or the dual immune checkpoint inhibitors with a high dose priming, so with CTLA4 plus durvalumab, 1,500 milligrams every 4 weeks. And switch to each other if there is no risk of bleeding to the anti-VEGF and anti-PD-1. If these fails, then we can consider TKI with lentivimab and followed by Rigo, Cabo, or Remi. For those patients living in areas where there is resource limitations or have contraindications to immunotherapy, then we go straight forward to the TKI. And I think this is really a very simple guidance, but in real life it would be more complicated, but at least we have some yardsticks to show how this flows and the logic behind. Now, the sixth question is how to monitor treatment response in patients with HCC treated with systemic therapy. One of the major concerns is the happenings with the occurrence of immune-mediated adverse events, and we have a few talks about these issues based on the Himalayas studies experience. For the dual immune checkpoint inhibitors, we have a high frequency of IMAEs, and though the severities is very similar, but we suggest that they should be monitored more closely if they have dual ICI, and for mono ICIs such as anti-PD-1 and PD-L1s, which is widely used in places like China, every 2 to 4 weekly. And for the response, we'll monitor the imaging by CT or MRI every 8 to 12 weeks for the treatment response, and if there is no treatment response, we have to switch. Now, the management of IMAEs related to systemic therapies, the essence is we have to be alert to the IMAE, and we have to detect it early by the close monitoring, and if there is anything to happen, then we should stop the ICIs and manage accordingly with high-dose corticosteroids. And many a times we can revert the status, and however, for those with severe IMAE, we might not restart the immune checkpoint inhibitors in the rest of the management. Now, one of the key questions, because a lot of the liver transplantation, especially in China, is conducted in patients with hepatocellular carcinomas, and recurrence is a big issue. So if the patients have a hepatocellular carcinoma recurrence after liver transplantation, so what should we do? Within the first 3 months, it's generally agreed that a TKI could be used, and beyond 3 months, then we might consider the use of immune checkpoint inhibitors in the forms of monotherapies or with atezo-bevo that could be considered. Now, liver transplantations is sometimes attempted for patients with many times with hepatocellular carcinomas, and who has been treated with ICI. So should they be considered for liver transplantation? This is incurs a lot of debates amongst the surgeons and my colleagues, especially in China. So, there is no consensus, but we generally feel that for those patients who has been treated and there is organs available, liver transplantations should be considered as such. So although the 3 months periods might be ideal, but in real life it would be very difficult. So because if the patients do respond to ICI or during the waiting list for liver transplantations, they need to something to be controlled the liver cancer, and ICI is being used, and they shouldn't be precluded from the liver transplantation itself. We also talk about the futures, and we have alluded to the multidisciplinary approach, which is really evidence-based, with all the data available to serve the best interest of the patients, to guide our therapies, the treatment response, switching of therapies, and management, and early detections of side effects. And in the future, we believe that artificial intelligence could be of great use in assisting, not dominating, the multidisciplinary team's approach in the management of HCCs to be treated with systemic therapy. And I think these are the simple recommendations we can come up with, and it is not as simple as we thought. It takes some time, and we have to apologize for the slight delay, but then it's very complicated. So I would like to, our team would like to see the response from the floor, and we are going to write it up as a small piece of the whole big pictures of APASL guidelines. Thank you very much.
Yes, thank you so much. I think George Lau concluded, maybe we got to discuss about the things that you just mentioned. So that's very important. So thank you very much. Well, because of time constraint, I got to finish this session. But I think number one, we got to get started about the HOC and then continue. So maybe they may supply and then answer so many clinical questions raised. And then secondly, we got to make a consensus, guidelines, at least systemic therapy. So thank you very much for your audience and the patience. Thank you.
Thank you, moderators, and thank you, Dr. Small.